Hello, everyone. Good morning or good afternoon, depending on where you are in the world. Hope everyone is safe, but I have a very exciting presentation. I'm going to show you a lot of stuff. Don't be overwhelmed. You'll have a chance to ask questions later. First of all, I want to thank WATERLASE for hosting this webinar and Xeramex for sponsoring it. I will be featuring Xeramex a lot today, but also I'm going to show you a lot of clinical applications on the laser, the WATERLASE in particular. I have used the WATERLASE for about 20 years, prior models all the way through to the modern I+. It's my favorite laser equipment. I studied my undergrad in microbiology in Alabama. And then I went to dental school in Göttingen, West Germany. And then when I graduated, I went to Cyprus. I had my practice there on the island of Cyprus. I had my practice there for 8 years. And then I came to the United States and jumped into lasers when they were just being developed for hard tissue applications. And ever since then, for more than 20 years, I've been using the WATERLASE in almost every department of my practice. As a disclaimer, I don't own any stakes in either WATERLASE or Xeramex, and I also place other ceramic or zirconia implants. I'll talk about that later on. And I love talking about lasers and implants because I'm a biological dentist, and I think these two entities, they represent a lot about the biological aspect of dentistry. But it's not about the biological only, it's about their merits for anyone concerned who wants to go a step forward and just kind of excel in their career as a dentist. So again, it's about the merit of using the WATERLASE. This is a hard tissue, soft tissue, hard tissue. You can apply it anywhere. And I'm going to talk about how to start or how we started. You know, anything we buy has a huge manual. It's almost like Murphy's Law. You know, you can almost say like the smaller the equipment, the larger the manual, and hardly anyone goes through the manual. But this is quite, you know, self-explanatory. You just have to, you know, start using it and apply it and just experiment with it. And by God, we have so much time these days that we can utilize all this time to just experiment. Just like you'll see in my videos, I've done a few video clips. I've taken my time in just making everything so, you know, understandable and see what effect it has on tissue. And believe me, I haven't really read manuals like in detail, but you get it down eventually, and it's very easy to use. And I have it set up in every room. You just have to think of utilizing it and taking the opportunity to apply it in any scenario you're presented with. And as you see here, I mean, endo, pedodontic, you know, like children's dentistry, perio, surgery, I use it in every scenario possible. Another important aspect is, of course, you have to advertise it. You have to put it up in your website, and you have to talk about it in your, you know, presentations, your treatment presentations, and your patients have to know that you have this, and you have to know the science behind it, and you have to lay out all the advantages and benefits. So I've written these down here. You can read about the benefits, less pain. By the way, never promise that it's pain-free. I know that there's some, you know, claims about that, and it's nice to know that most of the time it may be pain-free, but you will be disappointed, or the patients will be disappointed sometimes, and that's not nice to have them disappointed. So you have to let them know that if you experience something, it's less than your normal pain, or it's more tolerable. You just have to be familiar with what the laser does and how it's perceived by your patients. You know, today we're really concerned about same-day dentistry. We want to have results fast without jeopardizing the outcome. We want to make everything fast but efficient, and you want to heal fast. So this is all about the laser dentistry, really. And you have to tell this to your patients. Biostimulation is something important in lasers, even when you're using hard tissue applications, when you're drilling a tooth with it. You can actually achieve some anesthesia if you follow some certain techniques of defocused lasering before you start. But that's all for another day, or you can just go on their website. They have excellent videos. I'm not going to linger too much on these subjects. Return on investment, it's important. I mean, it's an equipment that isn't very expensive, but it may sound expensive. But if you look at the ROI in these things, like for example, one's code 4212 example I put up there, I use almost 2 to 4 times a day if I'm busy. Well, not these past few months. We have maybe 1 or 2 CEREC cases a day, maybe less, but on a regular day, we had up to 2 to 5 CEREC cases, crowns, bridges, and the 4212 code is for laser troughing to expose margins, and that's charged in my office at $220 a procedure. So some insurances pay for that, but patients have to know that it's for their advantage. And if you extrapolate that to a monthly revenue, it comes to more than $7,000. So now you have to realize that you're also doing your biopsies, your orthodontic applications, gingivectomies, perio. I mean, there's so much that you can make with this technology, and you can rest assured that it's for the benefit of your patient. So what does WATERLASE target? Again, I'm not going to go too much into the physics, but you have to know that it targets water. And as you know, gums, teeth, they all are made of hydroxy, well, not the gums, but the teeth are made from hydroxyapatite calcium phosphate, which is a hydrated form of calcium phosphate. And enamel has the highest concentration of hydroxyapatite. The prisms are also slightly hydrated, actually. But the WATERLASE use a water spray that sprays the target tissue with water. And if there's not enough water in the target, it'll still create these micro explosions in the water molecules that will break up the target tissue. And that's how you get your effect. So there's really no burning unless you stop the water spray and you're just lingering in one spot. Of course, it's gonna probably burn a little bit, but again, it's not targeting hemoglobin or other molecules except water. By the way, this picture on the bottom I like to put up there because it's of course it represents hard tissue, but it shows the first ever implants placed in prehistory, which are pieces of shell that have been just hammered into an extraction socket, and somehow they integrated and they survived until the death of this person, whoever he was. So Xeramex is a fully metal-free zirconia implant system. It's Swiss-made, and this is one of the systems I use, and they have 2 different versions. Of course, one, you can see them. One has a little more aggressive of a thread, and the abutments are fixed by carbon screws, and you'll see a little more detail later. Again, I won't stay too much on the research, but there's a ton of research on the compatibility of zirconia as a material for implants. And here, I just want to stress this one that just proves that zirconia surfaces repel plaque more than teeth. So if you have a periodontal situation in a mouth and you extract some of the teeth and you put an implant in there, you will not have periodontitis around that implant. So you're removing that, factor. And you also have gingival fibroblasts attaching to zirconia implant surfaces, which means that the gums actually adhere to the top part, which is less likely in titanium implants. And they fare better in the coronal 1/4 than titanium as far as integration. The laser effects, because we're talking about laser effects and laser applications around implants today, among other things, but you have to know that even if you hit the zirconia surface with a laser, it will actually have a beneficial effect, which is not the case with titanium. You're not supposed to scrape titanium or laser it directly. There's a lot of benefits to this. I think it's the perfect marriage between the lasers and implants in general. I use lasers with every implant case that I've used before. General research on biocompatibility, these are just a few of them. There's hundreds and hundreds of them on PubMed. And I have a database of them. If anyone's interested in a particular aspect of biocompatibility or zirconia implants, I can provide the research behind it. I'm not going to talk too much about titanium and its drawbacks. I'm a biological dentist. I never placed titanium in my life. I never place amalgam. I don't use metals at all these days, not even gold. We don't have to. We have excellent materials. And now, as soon as we had zirconia come up in the market, I didn't really have to look into titanium anymore because I could provide this solution to my patients. And I've done really well in zirconia, and they actually last a long time, and they're at least as good as titanium implants as far as longevity. These two research articles, I love the expression perio-integration, which means that the periodontal aspect of the tissue and the coronal aspect of the implant, it actually integrates with the periodontium, not only with the bone. So apart from osseointegration, we're talking about perio-integration. I've had cases where gums have grown over a healing zirconia implant, and then I've had to laser it off and peel it off the implant. They're so well integrated that it just grows onto it. What is zirconia? Again, it's chemistry 101. There's metals versus non-metals. It is a ceramic, so therefore it is a non-metal. It looks very radiopaque, even as the oxide in X-rays. A lot of people think it's a metal, but it's not. It's because it's very dense, and it's made out of zirconium dioxide. And the implants also have a few other traces of ceramics that give them strength. So it is fully metal-free, no magnetism, no heat conductivity. It's a perfect insulator. They actually use it as an insulator in nuclear reactors. So there you go. This video I made to demonstrate the basic steps of how to place a Zeramex implant, which a lot of people who place titanium will see that it's really a piece of cake for those who have done implants before. You just have to get used to the idea of it. I'm going to place a Zeramex XT implant in a model, and this is just an overview, a brief look at the instrument kit, but for our purposes here, I'm not going to go through the whole instruments and the burrs. For that, you may send me an email or Mike Foley an email, or just contact us and we will send you links for that. This is the round burr, just to spot the bone before you use the pilot drill.
The first burr is a 2.3. It could be a ceramic included in the kit or any metal 2.3 depending on the system you're using. And if you're using guided or fully guided systems, you just have to do the correct calibrations and just go to the correct initial depth. Assuming we have the surgical guide in place with the key that fits, and in this case I'm using a 2.3 millimeter kit, and I will be placing a 10 millimeter implant. We take the x-ray to confirm, and in this case it's a little short, so we have to go with the same pilot drill and drill a little deeper and take the x-ray again. If everything checks out, we just follow the arrow that points us to the correct sequence of the burrs, and we're following the 10 millimeter sequence with the first burr. The sizes of the burrs are color-coded, so are the burrs. So because we're placing a 4.2 diameter, we have to proceed to the next burr, which is the 4.2 burr. The next step is tapping, and we choose the appropriate color-coded burr, which should...
I have to apologize for using the wrong tabber, because I did a lot of video clips, and of course it should have been green, so I just want to stress that fact. We just have to be consistent with the flow of the instrumentarium.
Have been green. This is the wrong one. Please bear in mind. It should be the green tapping burr. Observe the threads, which should allow for the threads to engage when we're placing the implant in. The pickup burr, which has a little notch.
This is where that little notch is. It will break if you exceed, I think, 50 Newton centimeter. So it's almost like a guarantee that you're not going to break the implant, but rather break the burr, so you can just take the fragment out and extract it. There's also a rescue instrument that allows you to unscrew the implant if it's too tight and you can't get it deeper into its target.
Which would break if we exceeded a torque of 50 Newton centimeter. If we're down to almost within 1 millimeter of the final target height and the torque starts to rise, I will back up a little bit and then reinsert. But if we are short of 2 to 3 millimeters of the target height and the torque is too high, then we have to completely remove the implant and use some more drilling. The ideal depth for this type of implant is a little above bone level, but because of uneven bone heights, in some places we have 2 millimeters, in some places we have just 1, or it could even be almost a bone height, but I would rather place it a little more above bone level rather than deeper.
Xeramex has 2 options, or anywhere in between. It could be anywhere between 0.6 and 1.6 millimeters above bone level. Of course, as we all know, bone is never perfectly even. I mean, you see in this model that it's completely uneven, but it just gives you an idea. And in this case, for example, if this were a live patient, you would have to take the round burr and just grind away the lingual aspect of that bone where it rises up, so you have a relatively flat platform of the bone.
For me, the ideal torque is between 25 and 35 Newton centimeter for ceramic implants. They integrate better within that range.
all the parts are metal free.
So we will be trying in the abutments, and the bicarbo screw will be holding the abutment in the implant. The placement and initial tightening of the screw with the adapter. The bicarbo screw is a metal-free carbon fiber screw, and it is torqued to less than or up to 25 Newton centimeter. All you have to be careful about is to get a good engagement of the prosthetic burr into the slots of the screw. This Anthogear device is one of my favorites. I use it both for implant placement and also tightening the screws. And when you exceed the set torque, it will just snap. So we are ready to cover the access for the screw and to prep the abutment and to take impressions and to restore. I will next show you a live example.
So this was a live example of a lady restoring her number 8 tooth, or in European terminology, number 11, number 11. So as we see in the CBCT scan, we don't have too much bone, especially on the facial. So as you know, in dentistry, nothing goes perfectly, but we have to be prepared to adapt and to solve our dilemmas every second along the way. I think I used a guide initially, but I didn't like the position still, and I'm using a round burr to go a little more, to translate my entry a little more into the palatal aspect. Sorry about all this movement, because as you know, it's so hard to get a good video of live surgical procedures, but we're working on it. I'm spreading the bone here because I figured I drill up to about 2 sizes before the target width and then spread the bone, so I don't have to grind too much bone off. Inserting the implant. If you ask me, the facial aspect of the bone is too thin. I don't like that fact, and because of the limitation in the bone width, we had to go a little more facial, but angle it palatally towards the apical. So that gives me a slightly more labial angle of the implant.
And retract.
She had a fixed Maryland-style resin bridge, which we cut off during the healing phase. So now that bridge has been cut off. So now this is 3 months later, and we are exposing the implant with a laser. I don't use gingivectomy settings here. I always use a hard tissue setting, but I hike up the frequency and I lower the power. So one more thing that we have to learn when we're using lasers is while you're doing this procedure and using a loop, you're kind of getting a feedback of how the tissue reacts and how it responds. So you know your settings just by experience and what effect it has on the tissue. So basically using common sense. With these settings, there's absolutely no burning or charring. You will see no carbonization at all. And you get enough hemostasis. If you don't get enough hemostasis, then there's a technique to coagulate bleeding spots with the same laser, just doing some adjustments in these settings. So as we see here, there's a frenum that's very close to our implant, and I will show you, I will give you a bonus later because we have to do a frenectomy. But at first, before all that, frenum is involved and we get more bleeding, I just want to put the abutment in, the same system that I showed you on the model case before. But here we're using an angled abutment because you remember I told you the implant is facing too far labially, so we have to turn it back in lingually. Planning the prosthetics because there's still a little bit of composite left from my Maryland bridge. So we want to make sure that the space we have available for number 8 is the same width as number 9. Little details that you have to do before you scan for the restoration. This clip is from the surgical day. Sorry about the mix-up. It got edited into this section. Just showing you how I use the clip product from Voco. It's a soft, and I'm using it here too to cover the screw. It's a light curable rubbery resin material that is used to cover screws and can be easily retrieved. On top of that material, I'm putting a white opaque flowable composite so that we have the same, almost the same color as the implant. So this is important. You can prep zirconia abutments any way you want them. Just be careful, you know, that you don't over prep. And you can also prep beyond the margin that's provided for you just to, you know, go along the contours of the gum. And a lot of times, this is nice about the versatility of the system because, let's say it's just too far out of the gum, and you wanna take the margins down. A lot of times, I've even gone beyond the connection of the abutment onto the implant itself and place my margin on the implant in certain areas, and that's absolutely possible. I haven't had failures in those. Actually, I think it's a better way of stabilizing the abutment when part of the crown is gripping on the implant itself. So no problem with that. You just have to use a very new red striped diamond, and don't use too much force. A lot of water. Just follow basic principles so you don't damage your zirconia. I use CEREC for 99% of my restorations. We finish them on the same day.
Close up with the chisel.
Now here is your little bonus. I do frenectomies almost once or twice a week. This week we had 3 cases. Another return of investment situation. You can do it in 5 minutes, and we charge about between 600 to 800 a case. And there's not much wrong that can go with frenectomies unless you're doing an aggressive lingual frenectomy. Then you have to be careful with scarring or with you know, some numbness on the tongue tip. But there's absolutely no drawbacks in these, and the benefits are amazing. Here we need a zone of keratinized gingiva. We cannot have a frenum pulling along the margins of our implant. You will develop peri-implantitis. Got to make sure that you're zapping away the connections of the fibers all the way down to the periosteum. And you can easily create a wide triangle of ablation, and the area will be an open wound, but it will heal much faster. Yesterday I had a kid, a 4-year-old kid healing. I will post it on my Instagram. The mother said that she barely even felt any soreness after the procedure. This is called a chisel tip. It's the MC3 tip, but you can use an MZ6 tip as well, which are disposable. Remember, it's the laser energy cutting, even though you are somewhat touching this tissue, but it is laser that's cutting. It's not a blade that's cutting. So we're done with the crown, and this is your final X-ray. And that's the final picture of the frenectomy. This is an interesting case that I'm going to show you real quick. Opening orthodontic spaces in a lady who underwent extraction orthodontics, and which just created a lot of havoc in her system. So we opened up the spaces, and I'm going to put implants in here.
This lady had her bicuspids amputated during her orthodontic treatment a long time ago. This causes an array of problems which I will be discussing in a longer version of this case on my YouTube channel. In order to reverse the damages done, we decided to open the spaces for her upper premolars and then restore them with ceramic implants. I will not bother with all the details of the orthodontic steps, but suffice it to say that we are following standard protocols, including standard implant protocols later. Once we have enough spacing and good bone with proper root alignments confirmed by CBCT, we proceed. At the time, vertical release incisions, pilot osteotomy with a 2.3 or 2.8, depending on what system we're using. And this is a semi-guided protocol, which I'm not showing here. X-ray confirmation with a gauge. Countersink. The original Xeramex has the countersink, but the newer Xeramex XT does not. We have D2 bones, so we're using a tapper for the thread, and we are inserting a 4x10 Xeramex ceramic fully metal-free implant. So we are inserting 1 millimeter above bone level. I had designed the flap to displace some keratinized tissue labially, and the sutures are placed accordingly.
This technique I use about 80% of the time. It's always nice to have an extra zone of or extra thickness of keratinized tissue, and it helps a lot in the longevity of the implant. As you notice in the implant placement on the facial, there was more than 1 millimeter between the platform of the implant and the bone, but on the proximals, on the crest, there was absolutely almost no clearance. So it was almost bone level. So you're always going to get this unevenness, but I'll show you later when you own a WATERLASE, that's absolutely no problem. You can create your own contours. You can do your own little crown lengthening procedures, gingivectomies. We're going to get to that very soon.
After 3 months of healing, we are ready to restore and proceed to sculpt the gums around the implant with the WATERLASE. Here the gums are trimmed and a funnel-shaped emergence is created before we put the abutment on. We used a 15-degree angled abutment, mainly because the implant was facing labially. So I used the Anthogear torquing device to screw in the carbon fiber with 25 Newton centimeter setting. I then covered the access with my favorite material for this purpose, a clip from Voco. Notice the health of the tissues around the implant.
So again, you may notice certain discrepancies in the gums and the angles. So I'm actually using different clips from both sides of the mouth. So I have better video or pictures. I may have more pictures on one implant. So I kind of put them all together. But notice the gums and how healthy they look. They're all stippled and perfectly healthy, and how they've grown against the implant while it's been healing. Also notice how we have a problem with the angle of the implant and that distal bulge of the canine. So what we're going to do is we're going to prep more of a convergence here, and we're going to take a little bit off the enamel, doing some enameloplasty here.
Even though the implant is torque tested before anything else is done, now we are also using a perio test, which is not as reliable as a torque test for the two-piece implants, but it still gives us valuable data as to how firm the osseointegration has been. As we'll see here, the zirconia abutment can be prepped, and an impression or a CEREC digital scan is taken, and the crown is manufactured, and it looks pretty good, even though a little bit of the zirconia is shining through along the gum line, but that's better than black titanium shining through.
Again, different types of osseointegration. You can choose any one. I like the percussion, torque, peritest. You can do whatever you want. There's other systems too. Let's not go into detail here. So we talked about troughing. So we have to know what laser, what effects the laser has on zirconia. You just have to follow certain rules, but as I said, you have to be very negligent to actually damage zirconia using a laser if you're, a laser dentist. Just one thing, I don't like using diode lasers. They use a lot more heat, so you're not supposed to touch zirconia implant or titanium implant for that matter, because you will increase the temperature of the implant. Even though with zirconia, it's a very good insulator, so it will not travel through the implant. The heat will just stay where it is, but it may damage it if you use a diode laser and you linger on the implant too long. So basically, this is, you can say that this is not my bread and butter, but it is a very important step in all my restorative work because I don't like packing cord, and I can do this and sculpt the gums around any tooth or any implant and get a nice area of an emergence funnel, let's say, or exposed margins that are imprinted. Whether you're taking a silicone impression or you are scanning with CEREC, you want those margins to be perfectly clear. So again, as I said, I don't like packing cord. You are severing the delicate fibers around the zirconia, and as you know, there are fibroblast attachments to the zirconia implant, and you don't want to disrupt them, and the laser will not. You just laser off whatever you don't want, and you're not pushing or dissecting gums away from the zirconia implant. And also, you have a lot of uneven areas like hyperplastic tissue, inflamed tissue that you want to cut off, more like a gingivectomy, but you also want to create a nice troughing around the margins. So how are you going to do that? Are you using an electrosurge? I don't like cooking gums. I don't like the smell. Patients don't like the smell. And you create a zone of necrosis between 1 and 2 millimeters in the gums, and which is not nice. So some illustrations just to demonstrate the laser gingivectomy or troughing emergence pattern. So don't forget you're using a laser and it fires in a straight line. So this is not like a burr or an electrosurge where you cut sideways or you use a twist of the arm and you just kind of hit the side of the tissue you're working on or the tooth. So you're actually pointing the laser in the exact direction that you want the laser to work. So which means that you have to use a slightly longer tip and hold it in a direction as the green arrows here to create that funnel effect and to create a perfect emergence for that implant. So of course, you could put a healing abutment on this, but I don't like to place healing abutments on implants that are not submerged. In this case, I don't need them because after 3 months of integration, I can laser my emergence contour, and I can restore the crown same day. And if you have no cement excess and it's perfectly biocompatible, then the gums will heal around my crown just like they heal around the healing abutment. Notice here, if you have uneven bone and you're violating your biological principles, the biological zone, then you can easily raise the power a little bit, raise the water, and just do a little bit of crown lengthening around the implant. Very simple, same day. Some cases, this is the Xeramex, not the XT, but the first version, which has its advantages. Actually, I like using both systems, and slightly deeper placement. Of course, it may be ideal, but because these are also meant to be between bone level and gum level. So it's pretty good. And as you know, after the lasering, you have absolutely no charring, no carbonization. And by using refined lasering, then you can get rid of all these little tags and just kind of make it nice and smooth. So you can take your impression, or in this case, put your abutment. Again, talking about biological zone, the bone has to be addressed, and you just have to make sure that between the margin of the implant and the bone, you have 2 to 3 millimeters. So this is what I'm talking about. You just have to make that little calculation so you don't get too close to the bone while it's healing. Even though I've had a lot of cases where, you know, things don't go perfectly, you put the implant too deep or too high up. Too high up is not a big deal. It's very healthy for the gums, but sometimes you may need to go too deep, and then you don't want to extract it anymore, because then you have to, you know, then you have to repeat the whole procedure 3 months later. So but if you own the laser, then everything is a lot more, you know, flexible. Placing an implant, you can usually do a punch. Instead of a punch, I use my laser. A lot of times I like that displacing flap, where you displace the keratinized tissue facially. So I don't use the punch a lot, but sometimes if I have a lot of keratinized tissue, then why not? You know, after these procedures, a lot of times my patients don't even need painkillers afterwards. And you can technically even numb them just, you know, through infiltration. Luckily, you don't even need a block, because, you know, bone does not have nerve fibers, so they really won't feel much. But it's always good not to make them even anticipate pain, so it's nice to numb them. So as you see the funnel shape, the first slide, the first picture shows how it's almost fully covered. I think this is the implant which has the clip material. So I didn't put the healing cap on it because I like them to be low, so nothing interferes with their healing. And then this is the first phase of the lasering. There's still some rough tags around the area, so you just kind of go and refine the whole area, and make sure that if you're lasering, you have a straight line. You leave a little bit of this papilla, but you have a straight line upwards, so that when the crown is made, it follows a straight contour to the contact point. And here you see how the implant margin has been displaced to follow the gum contour, which is amazing. I mean, I love working with these abutments because you can prep them, you can create anti-rotation facets on them, so they're amazing. This is the finished product. Of course, the back crown number 18 was also redone, but this is the implant here, the crown made with CEREC. And you have to make sure there's no cement. I think this is the only weak link if you cement and you leave some cement. So you have to make sure the gums are numbed again if you're using CEREC, because the anesthetic will wear off, and then when you go in and scale, it will hurt. So you have to numb them again, and you make sure you go in and you scale everything out. Of course, you know, the ideal would be to have the margin at gum level, and you have no problems there. Another case, a papilla preserving flap and displacing the flap facially. Again, you see here the facial aspect. We have almost 2 millimeters exposed, and approximately you're very close to the bone here on the mesial. Notice the healing of the gums around the implant. Absolutely no irritation, stippling, pink, perfect. You can even see the traces of the displaced gum tissue. So we have a nice, thick, keratinized gingiva out here. Let's say you're lasering and then you have some bleeding points. So there's a technique where after you've shaped the margins and the funnel shape, then if you have some bleeding points before the abutment is screwed in or before the impression, then you switch off the water on the laser and you just zap those bleeding spots just for a second without water, and it will coagulate your bleeding spots. Same problem that we had in the other case, a big bulge of enamel here. So we will need to re-prep this and then do some enameloplasty and let the, of course, you have to inform the patient, and I've had no trouble with that. This is the final product. Again, this was made by CEREC, digital technology, CAD/CAM. And the final X-ray. As you see, implants are very radiopaque. It looks like metal, but it's not. It's zirconia, it's a ceramic, and one angle of my X-ray shows a little cervical burnout, and you may think this is not good, but then the other X-ray shows a perfect fit. Another interesting situation where we did a simultaneous extraction and implant. We didn't use a surgical guide, even though we had a CBCT, so we follow general lingual inclination, but you can't go wrong here because you're actually going along the roots, and you know you can't diverge lingually or facially. You're in the middle of where the crown was, so you just have to be careful extracting those roots and not losing too much bone in the process. I think that's the more challenging aspect of this. And also one mistake I did, I should have gone to 2 more millimeters beyond the apex. I could, because you see the nerve is way down there, and I had planned it longer in the CBCT, 2 millimeters longer, but I ended up not going that deep, probably 1 more millimeter. I could have gone another millimeter because in these immediate cases, you're relying on primary stability to be in the 1/3 apical region. And then the rest of it is grafted. And I use a mixture of Cerazorb or beta tricalcium phosphate and PRF in these cases. sticky bone. So after healing, again, you can't really predict too well where the gums will heal. You will lose some bone. So we had a little bit of exposure of the implant, but it was a posterior tooth, and I love these because there's absolutely no irritation to the periodontium. Sometimes you have to warn the patients that they have to clean in a different way. There will be a little undercut, so they usually have no trouble with that, but it's nice to know. And if it will be a problem, hey, just drill all the way down and put the margin at the gum level down here. There's no problem with that. The zirconia, company, the implant company may say, oh no, don't go beyond this, but I've done it a few times and I see no problems. So that's the problem you may face if the patient is not very keen on these little cosmetic, discrepancies. Then no problem. You just tell them it's really much healthier to have it like this. But if it's been a problem, then you just drill the margin down to the gum level and you solve that aspect of the problem. So I'm coming to an apicectomy situation. Now we know that, of course, this is a tooth that we want to keep. It's a strategic tooth that we don't want to extract and put an implant. So sometimes we have cases like that. And I've done laser apicectomies, and I have a really nice example here. So you just follow some guidelines, and basically they're the same guidelines as any apicectomy. But because we're a biological office, then we don't use amalgam as a apical seal. I hope none of you use that anymore. There's MTA or other bioceramics that we could use. And even if you don't have a laser, you can use piezo, and there's some nice technology associated with endo. So basically, you plan your case, you take a CBCT, and you make sure that you're entering at a level just below the lesion. You don't want to open up the cortex where the lesion is. Then it's really hard to seal the area. Then you will have an opening between the lesion. Let's say you opened it here, the flap is here, and then your whole lesion is here. So now you have a potential pump action of moisture going into your lesion that's trying to heal. So you have to go a couple of millimeters below and be in keratinized tissue. If you don't have enough keratinized tissue, then just do a full flap. It's much easier to secure those flaps with interdental ligatures. So I will show you a video of this procedure. And basically you just kind of follow an angle where you kind of see a bevel towards you, so you can see and access the canal. Extract that piece, and you thoroughly curette the lesion, and you will always find that there's always a wraparound part of that lesion where you have to go in with curettes and little curved curettes, periodontal curettes, just take everything out of there. And then you can also laser the walls with the hard tissue setting and just get it absolutely clean. That's the trough you can make either with piezo or with the laser. And now you have it ready for your apical seal. And if the lesion is too big, then you can insert some PRF for nicer healing, or you just leave it for a blood clot to stabilize the area if it's small enough. Okay. So this is a live case we've had. The tooth doesn't look good. I mean, I'd rather, you know, extract these teeth, but it's always a patient's choice. So this is a nice video of the setup of the WATERLASE. I think it would be very useful. So main power is switched on, and the secondary power, it's touch screen. It's under endo settings, so there's settings for everything. Everything has its pre-programmed, so you don't have to think too much. But I seldom stay in a preset program. I just, you know, tweak it around according to what tissue effect I want. There are two types of handpieces. There are two basic types of tips. One is a sapphire tip, which you can use multiple times. This one is a sapphire tip, and there are disposable tips. So here I'm showing you a sapphire tip, but in the actual video I have an MZ6 because the video is of a case that I did a couple of years ago. Now I'm going to show you a flap, and that's one reason why I chose this, because I try to do everything with a laser. So we're doing a curved flap within flattened tissue. So here you're basically choosing something that is almost akin to cutting dentin. So it's a hard tissue procedure. I'm using an MZ6 in this case, but you can use a sapphire tip as well. And you don't have to be too worried about higher power, because that's fine. It's a dead root. You just don't want to heat the tissue too much. You're using a lot of water. Now this is a root amputation.
Lay the rest of the root.
So with the laser, you have some limitations. If you have too many undercuts, you have to use curved direct to get everything out of here. This is a video I did to demonstrate the effect of two different types of tips. So this is the MZ6 tip, which is a little slower, but it will go through the root within a minute. And you can use higher power too, but as you see, we want to stay within a range where we're not burning the root tip. We're almost through. Again, a slight bevel facing you, so you can gain access and visual access to your canal. Creating the space for retrofill or apical seal. Just for the sake of it, I'm going to demonstrate the turbo handpiece, because this has a lot of cutting power, and it's got a tip that is more curved, and it's like a prism, and it has a focal point which is about 3 millimeters away from the tip. But once you get the focus, it cuts like butter. And this tip is used a lot for fissure cavities, hard tissue enamel settings. It cuts through enamel much faster than your regular laser tip. So it's going double as fast as the MD6 tip, and you'll notice how smooth its cut is. I think the only drawback in performing an apicectomy is getting the tip so close to the actual surface and into the flap, whereas with the longer NZ6 tip, you have better chances of getting it up to the wound without sticking your whole handpiece into the flap area. So this is amazing. It's just so fast. This is one of the bioceramics available. It's that comes with endosequence. This is also good for perforations, root perforations. Again, a quick summary of what we did. Use PRF for almost all my surgeries. If there's a big bone defect I have to fill, it creates amazing bone. And a lot of surgeons actually advocate not even mixing it with any particulate grafts. Especially on sinus lifts. It's a very safe way to perform a sinus lift because in case you have a tear or some little perforation, then you don't have your particles floating in your sinus. You just have PRF, which will eventually melt away. So let's see what we have here. Okay, so now we're going to talk about peri-implantitis. I know that it's been a big problem with titanium implants. And there's really no efficient way to treating peri-implantitis. It's just best thing to do is to avoid it. But let's say you have an implant that you don't want to lose, and this is one really efficient way to treat peri-implantitis without being too aggressive. Apparently there's this, there are certain bacteria that are more prevalent in peri-implantitis, but it also has to do with a very deep pocket with titanium. You have titanium induced hypersensitivity, titanium oxide microparticles that are ingested by monophages macrophages, I'm sorry, and they produce inflammatory mediators, and then you get inflammation. And then you also get titanium microparticles in the vicinity of the implant embedded in bone. So you constantly have this strain in the area where then you become more prone to peri-implantitis, especially around titanium. The only time I have had peri-implantitis around a zirconia implant is when something went wrong with the healing during the healing phase. And, but after it healed, I never had any incidents of peri-implantitis around the almost 300 cases that I've done with zirconia. But sometimes you do, and it's because of a certain defect, you know, or a wrong approach, or some part of a graft didn't heal, some risky procedure that you did along with the implant, and it just didn't allow it to heal properly. And so you have a peri-implantitis situation. Otherwise, there's no other reason for zirconia to develop peri-implantitis, because as we know, there is a very strong perio integration of zirconia implants. As a matter of fact, if you have a facial area with threads exposed, no problem. Multiple times we've seen cases where the gums just attach to the fibers and there's no problem. Whereas with titanium implants, that is absolutely risky, and you will develop problems later on, if not a gray discoloration shining through the gums and just looking awful. So this section of the video is from the WATERLASE website. It's a very nice video showing the effects of their system of treating peri-implantitis. I mean, it just says it all. It's an amazing video. It's an animated video and very simple. You just have to follow basic principles, really. I mean, this part where it says create a beveled incision and do your gingivectomy, it's just to remove tissue so that you're reducing the pocket depth, because as you know, there's a huge pocket when you have peri-implantitis. And this is what I mean. See that between the top of the gums, the gum gingival crest, and the bottom with all this junk in here, you have this deep pocket. So if I were treating this, I'd actually cut off or bevel off this whole gum area and just reduce the pocket length to half the original depth, so that you have to warn the patient that, you know, it's either this or you may lose the implant. So the drawback is that you may show more of the implant. If it's a posterior case, then no problem. If it's anterior, then good luck with that. So the side firing tip is what is being used here. The laser beam comes out at an angle sideways, and it hits both the implant threads and the gums. So you're performing a very non-invasive gum curettage at the same time as debridement of the threads without using any curettes. And as you know, it's totally contraindicated to use instruments and scalers around titanium implants. You may clean it to a point, but then it's just gonna get worse, because now you're gonna have all these damaged surfaces along the titanium, which will create more corrosion or more titanium or titanium dioxide particles. Of course, we want to create bleeding, so this is what this step is about. And in addition to that, I use ozone gas. This is a case we had with some remaining laser
here. Feel anything?
some remaining titanium
Discomfort? Let me
implants
know.
that a patient did not want to remove. He lost a few, but he had these to act as a retention for a partial he had. So we just did some treatment on them. They were in bad shape. So now we already have some healing from earlier treatments. And now we're doing the actual peri-implantitis treatment with a side firing tip. We take our time, just go and walk around the implant. The patient is numbed because we're going all the way deep down into the pocket. And it's like a walking probe. Just take your time and don't force the tip. Here you kind of rely on your tactile sensation, so you're not actually like pushing through the fibroblast attachment at the bottom of the pocket. In between, we're irrigating with some peroxide, and now we're bubbling some ozone gas into the pocket. This is the last thing we do. So as we said, there may be a scenario where you had poor healing around a zirconia implant. And this is one case that I did an open flap because it was just not healing well. And this was one of my only case where it was just not going well. And the implant was very stable, so I didn't want to lose the implant, but this is what we did. So here we're using a direct ablation of all the granulation around all the threads. So I'm using a power that's kind of the denting setting, a little defocused, and just pointing it straight along the thread, but just continuously moving it around. And just make sure that you remove all the granulation and take your time. So direct visual control is the best way actually if you have to do it flat, but otherwise if it's moderate peri-implantitis, you don't need it flat. So it was quite a long implant. So it was very stable. If you remember, there was that research article that mentioned that if you radiated a zirconia surface with 5 watts of power with a WATERLASE, it actually created a surface which was highly compatible with fibroblastic or osteoblastic cells. So you would actually have a better surface. Apart from the fact that you're removing all the biofilm and the granulation, you're now creating a surface that is very open to growth and attachment from new osteoblasts. I'm done a little earlier, but I have one more video to show you. If you would excuse me, let me go find that video.
Great job, Dr. Sarkissian. Thank you for explaining everything there is about ceramic implants. What a great fit, ceramic implants and the laser. It's just a natural fit. You did a great job of explaining all of that. So thank you. I think your presentation was great, and the drawings that you've made yourself. Nobody knows that that's a hidden talent you have, and it helps tell this story. You know, I really thank you for explaining a bit more about ceramic implants. You know, there's lots of misconceptions out there regarding ceramic implants, and you clearly showed that the Xeramex XT is a two-piece, tapered internal connection, entirely metal-free system that basically functions just like a traditional titanium implant. They've evolved quite a long way. You went into some of the strength characteristics on the implants. You know, the previous generations 15, 20 years ago, where a lot of people think they have fracture issues. A lot of that has been resolved. So thank you for sharing a lot of that stuff. I just wanted to quickly jump on, introduce myself as the representative and CEO of Xeramex in the United States. Given this opportunity to partner with WATERLASE and share your story, we made a little offer for all of the viewers. I'd like to invite anyone to go to Xeramex USA /offer. And they can register, and we will mail them a macro model 1:6 scale replica of our ceramic implant system, as well as some patient flyer, patient education information. Maybe you want to share a little bit about how you're able to differentiate your practice with ceramic implants. I think that, to me, that's one of the biggest opportunities here. Again, thank you.
You can still hear me, right?
Yes, doctor,
Yeah.
we can.
Okay, perfect. Yeah, I want to say that, you know, before the ceramic implants existed, almost all my patients did not want titanium implants. Even back then, 20 years ago, 10 years ago, you know, when they lost a tooth, they just didn't want any implants because, you know, people just don't like metal inserted in their bodies. And regardless of the fact that there are millions of titanium implants out there in people's bodies, but a lot of times, you know, nowadays people are a lot more educated, and they're going online and researching and seeing, you know, all these drawbacks of titanium and metals in general, and mercury, and of course, it's not only the titanium, it's the alloy and all the other ingredients along with the metals. And people just don't want it. And it doesn't matter how much you argue that, oh yeah, they're safe, they're this, the ADA approves them, but it doesn't matter. You have to give them a viable option. And when the Xeramex came out and the other ceramics came out, it was like a blessing, you know, sent to us. And I just jumped on them, and it's been amazing. And you know, you just follow certain guidelines, and there's no way you can go wrong. And it's not, just like you said, in the old days, like 40 years ago, when they were just starting to experiment with ceramic implants, of course they were breaking because some of them were made from aluminum oxide, or just you know, other materials that were not as strong as these hip pressed implants. The zirconia is a specific ceramic that is actually pressed under heat and pressure, right? It's a very break resistant. I've had one breakage in my whole 10 years that I've used implants, just one break, and that was the wrong choice, the wrong diameter, and a very heavy bite. So other than that, I've never had any breakages. That's not an issue anymore. And there's a lot of surgeons who go around and tell their clients that, oh yeah, they break. It's just a cliche that's just stuck. And it's because of non-information or ignorance towards the latest developments that have happened over the past 10 or 20 years. And there's a huge track record of zirconia implants today than 10 years ago. Right? I mean, what do you think, Mike?
Yeah, absolutely. You know, there's actually lots and lots of studies and many more coming out all the time. You know, we're working with top clinicians around the world are bringing ceramic into their practice. You know, one of the things that you kind of talked about is you're a busy practice in Los Angeles. I don't know how many doctors there are in Los Angeles that are offering implants, but you have found a way to differentiate yourself by offering a metal-free option. And you know, now that you have a system that works like traditional titanium, this is something that many more offices can get into and not fight just on the price. You know, you're driving down the down past LAX and you see the sign for what, like $1,000 dental implant. You know, this is, don't compete on price, compete on aesthetics, cosmetics of a white natural implant. Anyway, thank you for a phenomenal presentation. I think you've got a group of questions here, so I'll let you take care of those.
Yeah, thank you, Mike, and thank you, Dr. Sarkissian. As Mike suggested, Doctor, we do have some questions, so if it'd be okay with you, could we get after those?
Of course.
Terrific. The first question is, how do you peristeel scoring after frenectomy with WATERLASE?
Can you repeat that?
Sure, I'm reading it verbatim, Doctor, so it might have been a typo, but how do you periosteal scoring after a frenectomy with WATERLASE? Maybe it's prevent scarring. Ah, there we go.
Oh, scarring.
How do you prevent scarring? Yes, there you go. Sorry, it literally, I'm reading verbatim and I can just tell it's a typo.
Yeah. Well, as I said before, scarring sometimes happens, and some people are more prone to scarring than others, but scarring happens more on the tongue. But I've really never had scarring on the labial. And as a matter of fact, there is a tiny little scar that you can get where the new attachment is, and which is really not a huge scar. It's just a tiny little demarcation where you see the new attachment, and below that so-called scar is all that extra keratinized tissue that you're forming. So it's not an issue really. I haven't really seen significant scarring issues or any scarring really that would affect the outcome in labial frenectomies.
Okay, doctor, and
one more thing, actually, it's very important to do the post-operative exercises. You have to continue stretching, or tell the patient to continually stretch the lips and even the tongue. I mean, it's even more important with the tongue, because a lot of frenectomies for the tongue are done because of issues with tongue placement, phonetics, swallowing. So it's really, there's a lot of medical problems associated with a tongue tie. The best results you get from a lingual frenectomy is when you have a band that is very thin. It's very tight, but it's thin and it sticks out. If it's a broad frenum to begin with, then it's harder to get spectacular results from laser frenectomy. You may get a few more millimeters of extension and tongue, but then you may also get some scarring with the tongue.
Thank you, doctor. And this is from the same participant, a follow-up question. Is it okay to use metal retractors while using WATERLASE or any other dental lasers?
Well, we use metal instruments a lot, and in order for a laser to have an effect on a target, it has to be within 3 to 4 millimeters, because that's where the focal length is between the tip and the target. So if you're pointing a tip on a metal instrument or an implant, or regardless of what kind of metal it is, if you're pointing and touching metal with your tip, you're going to damage the tip. So the tip will just kind of crack in the, or it will lose its integrity. But as far as dangers from scatter, there's really not hardly any scatter from the WATERLASE when you're using it on tissue, because it's just fully absorbed in water. So there's absolutely no problem in using metal retractors or metal instruments in dentistry while you're using a laser. And that brings me to that question of safety, actually. We have special glasses for goggles for protection from BIOLASE, and both the patient and me and the assistants, they have to wear them. But theoretically, if you point a laser to your light, to your eye at this distance or up to here, theoretically it doesn't have any effect. If you point a laser pointer into your eye, you have a lot more damage than if you point the WATERLASE. So not that I'm encouraging anyone to do this, but
Of course not.
the whole theory behind it, because it gets
Sure.
absorbed in water, and as I said, you have only this much distance from the tip to the target tissue in order for it to have any effect. That's one point I wanted to make.
Thank you, Doctor. These two questions are associated as well, so it's one and a follow-up from Dr. Kwong. I believe the first one is, when doing APICECTOmy. I can't speak today. I'm so
Nobody
sorry.
can pronounce
Thank
these
you.
words, I know.
Is there? I should try that 3 more times. I apologize. Is there a minimum amount of the root tip that you remove, or does it just depend on the extent of the lesion which you uncover?
Oh yeah, it depends on the extent of the lesion. Of course, in your CBCT, you have to kind of see how much bone you're going to be left with after the lesion, beyond the lesion. Like if half of the root is enclosed in the lesion, and then you're looking at a tooth that will have only like 5 millimeters of bone left in healthy bone. So you might want to tell the patient, maybe it's better to extract that tooth. But I mean, there's a lot of advantages in using the laser, because now let's say you have a lesion that encircles 3 or 4 millimeters of the apex. I like to, well, at first, as I said, I want to put the flap where I'm beyond my cortical window, so that I have good closure. So beyond that, so I want to have the root amputation done at a level not beyond 1 millimeter of the extension into the lesion, because if you leave more root, then you have to somehow reach behind that root and keep curetting. Otherwise, you're going to leave granulation tissue. So ideally, you want to be like within 1 millimeter of the root extending into the lesion, so that you can have also good access and hemostasis while you're doing the apical seal. Hope I answered that question.
I think you did, Doctor. Thank you. And from the same Dr. Kwong, just a bit of a follow-up. The same question for laser troughing prior to CEREC impression capture. I think the idea is, what do you look to take away there to get the best impression?
For simple troughing, which is the ideal case, really. I mean, if I have a margin, a lot of implants are gum level or slightly below gum level. And all I really take off most of the time is a little bit of epithelium just to expose the margin. That's all we need. But of course, life is not that ideal most of the times. And, in surgeries, you have deeper placement, or you have healing that doesn't go as predictably. And now you have to remove a little more. But as I showed in my diagrams, sometimes you have to take a little more. And then you have to have an emergence for the crown built in with your laser. So it's really a huge variance between just a tiny little trough to a large funnel-shaped emergence. And I also treat the implants just like I treat teeth. Sometimes you have a huge amalgam you're removing with a lot of decay that's going down all the way into the root. So now you have to put a crown or an onlay. And how can you put the margin at a point where you're almost at bone level? So now, I mean, for me, no problem, even though the patient has to understand that this is a guarded situation. But now you're doing the gingivectomy, and now you're at the bone, and your margin proximally is at the bone. So implant or tooth, it's the same principle. Now you have to increase your power a little bit, increase your water, and just start performing a bone, you know, hard tissue procedure, a crown lengthening procedure. So you're taking away 2 more millimeters of the crestal bone so that you have a margin for your crown that ends at least 2 or 3 millimeters above your bone level. So, but when you're removing bone, then you have to also trim your gums accordingly. But as we know, gums grow according to where the bone is. So it's like a biological program that it doesn't matter if you remove too much gums from the proximal, as long as you have the bone in the right position. And then with proper hygiene, the gums will grow to their predetermined biological level. But that's very important because we face this every day. We remove amalgams, we remove like old crowns, and there's decay into the roots, and we somehow have to solve that problem. And with a laser, it's a guaranteed same-day procedure that would avoid, you know, months of waiting or sending out to a periodontal surgeon to create a surgical, you know, crown lengthening. And then you're waiting a few more months, and then it's just a forever back and forth for the patient. But right now, you're just doing it right on the spot, and same-day dentistry. That's all it comes to. And if you follow those principles with the bone level, then you don't have any problems.
Terrific, doctor. Thank you. A couple last questions. They're a bit simpler. This is from Dr. Sousa. What tip do you prefer, Dr. Sarkissian, for refining the gingiva?
My go-to tip is the MZ6. I really just play around with the settings. Refining the gingiva is, it's very interesting. You can, if you play around with laser, you can have different effects, even without changing the settings. Just by defocusing, you can actually trim the gingiva. If you're, you know, if you're in a hurry and you don't want to spend a few more seconds playing around with the settings, you just defocus and then you're still trimming. So basically, it's almost like an energy directed at tissue, which now when you're defocusing, the energy is weakened. Or you just drop the power on the settings, or you keep the power the same and you increase the frequency. So with the frequency, each tiny pulse carries less energy even when the power output is the same. So by playing around with those, you can actually do such refined procedures just by either defocusing or changing the settings. And that's amazing because with loops, which I failed to mention before, you have to be able to have proper and high magnification loops if you're a laser dentist, because you're getting your feedback from the effect that you're seeing microscopically through your loops, and then you're kind of gauging your position and your power based on that.
Perfect. Thank you. And the last question is more towards the implantology side of the lecture. So I'll read it verbatim again, Doctor. It's a question about the placement of the implant, and I don't know which case it's referring to, but perhaps this will connect to one of your cases in your mind. Why did you place the implant to the buccal? The buccal position of implant normally would prevent you from using a screw retained crown. What about buccal plate resorption later on? And again, forgive me, doctor, but I read that as verbatim as I could.
Yeah, that's always a problem. I think buccal plate resorption, in that case that I showed you, or other cases, similar cases that I've had, zirconia, you have better chances of zirconia preserving the buccal plate than titanium. That's one little factor you have to factor in. The second is, of course, you have to make sure that you're following general guidelines. And in that case, I showed you the number 8 case. It probably had just 1 millimeter of bone on the buccal plate, but it's still good. It's still there. Another problem that you have to worry about is keratinized tissue over the buccal plate. So if you have a thick tissue over the buccal plate, you still have less chances of resorption. The third is, when you give them an appliance to wear, you should avoid that appliance, whether it's an Essex or a little flipper. You should avoid it impinging on that buccal area. You have to stay away from that buccal side. I had one case long time ago. It went perfectly well, and I had an Essex that was given to the patient for cosmetic purposes, but also to protect the implant. Some time ago, we had one-piece implants, and we had to make sure that the patient was wearing a protective device with space inside so that the implant would heal. And nothing would, was allowed to touch that implant. So the edge of that Essex was just kind of gently touching the part of the buccal plate. And a few weeks later, there was inflammation, and the patient lost the whole buccal plate because of that. But that's my only case of buccal plate loss. Otherwise, I had to angle the implant facially because of my CBCT study. If I had to take the apex palatally, so the coronal aspect came a little more facially. Of course, it's always a challenge, and I'm sure it's a general implantology challenge that you have to make sure you follow, and a lot of times things don't go as planned. But if you're kind of diverging from your ideal, then you still have a lot of flexibility because you have the laser. And at some point, if it doesn't go well, then it's always a choice. Just like any other implant, you abort and then you place a larger graft, and you just kind of run it by the patient and see what kind of patient you have. If they're very keen on that, or if it's a highly cosmetic case, if you want the gingival level to be level with the adjacent teeth, and there's all this cosmetic stuff, then you, of course, you have to abort the implant and plan a gingival architectural, surgery and make sure you. But in normal cases, I think you have to have an understanding of what you can get away with. But I'm telling you, you can get away with a lot more if you have a laser and if you have zirconia as a material, because zirconia is a lot more forgiving if you have aberrations from your ideal.
Terrific, doctor, and thank you. That concludes our questions. There's been a number of positive comments about your candor and your real world experience and how much of that you're willing to share. So thank you on behalf of the audience for all of the great clinical examples and sharing your expertise and experience, not only with the ceramic implant systems, but of course with the lasers in conjunction. Your patient outcomes are just beautiful. So thank you again.